Good morning, everybody. Good morning, everybody, and welcome to AM Impact on Your Health. AM Impact on Your Health, where every day our goal is to have you learn at least one thing to help you live better and longer. AM Impact on Your Health is heard each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney, and I'm with you each and every Monday, Wednesday, and Friday from 8 to 9. AM Impact on Your Health, for each day you'll find current medical news, knowledgeable guests, fascinating health topics, and of course, where we do encourage you to call in to join in today. Well, it's so nice to be back and have an opportunity to speak to you live and in person. If you didn't know it, I was gone for an entire week last week, literally having the experience of a lifetime, actually, or at least in a long time, with a group of like-minded people who attended the 8th annual, now this is my first, the 8th annual Microcurrent Conference. Now you're in store, Pittsburgh, to be exposed to a new paradigm. I'm going to call it a paradigm shift. It certainly is. Wonderful things can come your way, I believe, when starting to consider how microcurrent can work in your behalf. I'll give you more of a report on that and how that all went out there. And by the way, out there means St. Petersburg Beach. What a lovely place it is. And had an opportunity to meet a whole bunch of folks from the United States that are doing what we're not. And of course, it is my honor and privilege to bring to you what other pockets of the United States have already experienced and are experiencing each and every day, because they have certain practitioners in their areas that got this message a little earlier than me. Anyway, I might be a Johnny-come-lately, but not late enough to miss it, and I'll report to you right after one of our breaks. Today I'll break into a segment on that. So let's see. I hope you enjoyed. By the way, a little special note. I repeated the Jerry Tennant shows. Why not? I mean, the man's as brilliant as they come, and I have to say that in recent times, there's not been one single guest who has caused our phone to ring off the hook after the show is over than the Jerry Tennant show. So we repeated them on Wednesday and Friday. I got a nice little twist to that one I'll tell you about before the morning is up. But now let's take a look at the schedule and see what we got up and coming for you. So on Wednesday, folks, I'm talking about Susan Smith-Jones, Dr. Va Boom herself, will be back. We missed her in September. We'll find out where in the heck she was. But she'll be reporting in on Wednesday morning with you. And then as we move into next week, don't forget it's the third Thursday of the month next week. That's the 16th. And as we like to do, we're going to bring you the speaker that is going to be invited to speak to you out there at the Freedom of Choice and Cancer Therapy Group located at the Riverside Landings in Oakmont, 7 o'clock. This particular month's guest, her name is Susan Silberstein. Let me get that bio on her. Hang on. Where do I have you? Anyway, Susan Silberstein's coming in from Philadelphia, and she's involved with cancer treatment in a way. Here she goes. President of the Center for Advancement of Cancer Education. By the way, you can check her out at beatcancer.org in the interim, which she founded in Philadelphia in 1977 after the death of her young husband to cancer. Well, everyone has their epiphany in their own way. Unfortunately, this appears to be that tragic beginning, but good things came out of it, and Susan Silberstein will be coming to Pittsburgh to talk to you. What a group. I mean, to bring Susan Silberstein, PhD, it's Dr. Susan Silberstein, to the austere group whose original formation was based on freedom of choices in cancer therapy, I think is a bit of brilliance on the part of Sylvia. We're going to have her on our show. She'll be here 1 week from today, next Monday, in preparation for the visit here on Thursday. Then the following week, I'm going to introduce a guest to you. You'll see what I mean by this, and I think she's going to be a frequent visitor to our show. Her name is Shannon Gosen, and I want you to just become aware of the name. She is a rock star in the microcurrent world, and we're going to be dedicating a lot of time to this, what we'll be able to prove, I hope, this morning, is a paradigm shift you don't want to miss. You've already missed it, folks. No one in this area has been really bringing this to you. There's some isolated practitioners, but they're so isolated you don't even know about them, and I hope to be able to introduce you to them. Anyway, Shannon Gosen is going to be making her first appearance on our show on the 20th. Circle that one. That's going to be a big date. You don't want to miss it. Our protocols are coming up this week. Next week. We have our October eye treatment protocol. You know, we do these one a month, and we've got a nice group coming through starting next Monday, Tuesday, and Wednesday. They will arrive with all of their afflictions and their eye disorders, which have no real treatment in conventional medicine. And in 3 days, we hope to be able to reverse, and we will reverse. And we will reestablish some wonderful improvements in their vision in 3 days. You've heard about it so many times here. If you, and this probably today and tomorrow are the last days, if you have an interest and you'd like to be involved in this particular October 3-day treatment program, give us a call, 724-942-3002. Talk to Sister Sarah. She will get you with all of the documentation you need quickly so that we can get those records off to Dr. Edward Condrat, the ophthalmologist who is on every single case that comes here. And then, of course, when we start our 3-day treatment program, Dr. Lisa Bowen is involved on day 1 doing assessments and involved once again on day 3 reassessing, and then we get to be able to report back to you and certainly to the group on how much improvements that occur. And they're phenomenal is what they are. Anyway, the eye treatment program, especially for those afflicted with macular degeneration or glaucoma or diabetic retinopathy, cataracts too, trying to avoid that surgery, and you should try to do so if you can, and in the greatest number of cases you can do it by involving yourself with this treatment program too. Once again, the number, 724-942-3002. And as the schedule is set right now, and I only mean the word right now because I have a bunch of cards from the various people that I met at the Microcurrent conference, and as I begin to sign them up, and I let them get back home where they could actually see their schedule, and I'll be checking with them this week, and you'll be seeing a whole bunch of folks who have specific contributions to make in the microcurrent realm, which I'll be bringing to you because we got to take the lid off of this one, and I will talk to you about that right after the first break. Let's move in, however, to a particular time of the year that I get very irritated. It happened while I was away, so it was very subtle. I would have picked up on it immediately had I been here. But of course, you could not watch anything involving football on Sunday in the NFL without seeing Code Pink once again. It is that time of the year. They refer to it as National Breast Cancer Awareness Month. And by the way, let's get this straight. I absolutely support the message of breast cancer awareness. I would like to support all that's being done. I can't do that, but because unfortunately the connection that gets made between National Breast Cancer Awareness Month and the messaging that comes along with it is, it's time, ladies, for you to remember, get that mammogram. And I heard so many sports announcers stumbling through the mammogram issue yesterday. And all I want you to do is, hopefully, as this month goes on, be paying attention to the message about should I get a mammogram or shouldn't I get a mammogram? It's one question that I never really answer for patients. I never tell them to do that or not to do that. But you really do need to be able to make an intelligent decision, and rather than being caught up in the moment, the emotion of the October and the NFL experience and all that, to make you feel really good about having a procedure that I think has some serious questions that need to be asked before you make that pilgrimage to your local hospital, usually other outpatient facilities. And let's just fill in some of those gaps right now so that you can hear me repeat them multiple times throughout the month. Number one, I say there are three reasons that you really need to consider mammography as to whether or not you should subject yourself to it, ladies. And the first of these three items is one that I usually message with one word, and one word only, because the one word sort of captures the problem here, and it really is a problem. And that one word is the word squish. Now, I won't elaborate on that other than that, but women who have had mammograms, you know what I mean when I use the word squish. I've been involved with mammography from a clinician side. I've watched the barbaric process that mammograms have to undertake, and that really the breast tissue really needs to be severely compressed in order for them to get the best possibility to see whatever the heck there is that they're looking for. And this is a very uncomfortable procedure. I don't know many women who look forward to this, but dutifully do it because they believe they're working in their best medical interest. So the word squish says it all, and I think that's reason enough to consider maybe why you want to avoid having a mammogram. Number two, the battle cry of the conventional medical community, and certainly the NFL all day yesterday, is that the best protection against breast cancer is early detection. Best protection, early detection. And actually, that's 100% correct. I think that that really does sum it up. And I'm all in favor of the earliest detection to be able to get that protection. But unfortunately, and I'm pretty much clear on this, I'm adamant about it because the literature supports me on this, the mammogram really isn't a tool to early detect. I know that's shocking to you because, well, why would your doctor order it if it really wasn't able to early detect? And let's not worry about the motivations of the doctors who are compelling you to get this study done. Let's just say this much, that the size, the dimension of the lesion that has to be present in order for the mammogram to be able to detect is somewhere around 1 centimeter in diameter. 1 centimeter. And that's just too late, folks. And the reason why is that whenever you have heard of, and if you haven't, I'm now going to reveal to you, I think I do this annually for sure, what we have referred to around my office as the Courtney 1 millimeter rule. You won't find it written anywhere, yet every time I'm around my doctor friends, I happen to tell them, hey, look, would you listen to this? This is a rule that I've mentioned to all my female patients, and if you think this is an error, let me know, because I wouldn't like to be spreading bad information. And so here it comes. The Courtney 1 millimeter rule goes something like this, and that is, anytime a malignancy has attained the size of 1 millimeter, that would be 1/10 of a centimeter. Anytime a malignancy has attained the size of 1 millimeter, it's already out there and has metastasized to some other place in the body. That is a pretty phenomenal statement, but yet I can tell you, I can report to you, that when I asked my colleagues, my medical colleagues, my doctor buddies, hey, what do you think about that statement? Do you think that's accurate? They pondered for a moment. They looked back at me and say, you know what? Seems like that's pretty much spot on. So 1 millimeter is soon enough to detect. 1 centimeter is not. Unfortunately, what happens whenever we make a detection, and by the way, there's a lot missed with these, women with dense breast tissue, 1 centimeter of lesion is not visualizable. And so women out there, and you know who you are, you end up requiring 2 studies every time you get the mammogram, because one is a radiographic study, but the other because of dense breast tissue and really not being able to see even a centimeter or sometimes much larger lesions they've got to do ultrasounding and to be able to at least find if there's some structure there, and then they'll try to put the two together. So the issue of 1 centimeter, though, is 10 times beyond where you really need to detect. And there is my problem right there. If there's the biggest problem, as I see it, is this tool that every October is sold as though it is the panacea to the breast cancer issue is absolutely, positively not. And so therefore, to expose yourself, ladies, to the squish under the rubric that this is somehow a wonderful way to early detect and inform you that you have a problem and then can do something about it, that really isn't in the cards for mammograms. Just won't happen. What will happen is if any lesion is detected, assuming that it has already acquired the size of 1 centimeter, then you will be placed directly into what I refer to as the kabuki dance of breast cancer. The next step in this dance is that you'll be asked to get a biopsy. At the same time, and usually they do them at the same time, you will be counseled by a surgeon that they will do a lumpectomy. And once the lumpectomy is done, and as the patient emerges from the anesthetic, because they normally do these under general anesthesia, the surgeon dutifully waits at the bed, the family is present, and the surgeon announces, let me tell you this, I got great news, we got it all. And of course, this is wonderful news to hear. If you're the patient who just allowed themselves to be surgerized to be able to get to that point, the husband is elated, everybody in the family is elated. And then that surgeon isn't done speaking yet. Because the next sentence, and it is the next sentence, and it's never missed, and it's always coming. You don't anticipate it as the patient, but the surgeon knows doggone well this next sentence will never be avoided. And the next sentence goes something like this. And so, yes, we got it all. And by the way, on Monday morning, your chemotherapy will begin. Now, at this point, the patient and the family both are looking at the surgeon with incredulity, saying, what did you say? And the surgeon says, well, no, your chemotherapy will begin on Monday morning. And now there's some confusion on the faces of everybody in the room except the surgeon, because they say, hey, you just got done telling me that you got it all. So if you got it all, why am I scheduled to have chemotherapy on Monday morning? And by the way, folks, that's the way it's going to work out. And then the answer to the question will be something going like this. Oh, okay, I see. Look, when I said I got it all, I meant I got all of that, meaning the lesion that was in the breast. I couldn't possibly get all of any metastatic spread because I don't really know where that would be. There's no way of telling where the metastasis has spread to. And there's the first time the word metastatic spread has ever been brought up into the conversation. Up until this point, it's only been that lesion, a biopsy, a lumpectomy, and everybody's thinking, oh, I just get this carved out, I get this taken care of. We have no issue here. And it's only at that moment when it's announced that your chemotherapy begins on Monday morning, it's only at that moment that honesty, full honesty, finally penetrates the room. And I think that is a shame, and it's a travesty that it works in that way. And I don't think chemotherapy is ever discussed before the surgery, because if it were, the dichotomy, the absolute absurdity of the two statements, I got it all and your chemotherapy begins on Monday morning, would play itself out before you ever got to the lumpectomy component, and it would create a lot of problems. I don't know how many people would allow themselves to be subjected to that lumpectomy, because here's the true fact. Women with breast cancer do not ever succumb to breast cancer that's confined to the breast. You don't die from breast cancer confined to the breast. You only suffer those kinds of consequences due to the metastatic spread, which is the most important component of this disease process, and particular vulnerable areas that actually can lead to the demise of one of these unfortunate individuals. Or what if that metastatic spread has gone to the brain, which, by the way, it certainly can, or the lung, or the liver? These are the three big areas where there's going to be a heck of a price to pay at some point. So, back to point number two. Point number one was squish. Point number two was the battle cry of the best protection is early detection. Absolutely confirms the fact that the mammogram is not the tool to use ever to early detect. It can't detect early enough, way beyond the 1 millimeter component, usually at least a centimeter before the mammograms can be positive. And so, as to whether or not you should be subjecting yourself to a study that only can foretell the confirmation that you have metastasized, is that's a real thing to ponder. Point number three. I told you there were 3 points. Here comes the third. The X-rays that are being used to perform mammography are ionizing energy. It is ionizing energy. And so when mammograms are given, there is one rad of energy that's shot at this breast tissue from up to down, meaning superiorly to the floor. And then there's one rad of energy shot from the outside of the breast, sort of the peripheral side, into the medial side. So there's one rad down, one rad to the side. That's one breast, the other side, one rad down, one rad to the side. So there's a total of 4 rads of ionizing energy. This ionizing energy is so well documented to be able to provoke the very cancers that you, I think, are trying to avoid. And so this constant exposure to X-ray is a problem unto itself, and literally has the potential to provoke the very thing that you are trying to avoid. These X-rays are not innocuous. They damage DNA. And once damaged, these, as time moves on, these in this injury to the DNA and this damage to the DNA doesn't fix itself. It's permanent. And so the next time a woman gets that study and more damage gets done to the DNA, that is added on to the last time around, and so on and so on and so forth, so that really, at some point, you really are increasing your risk considerably to getting the very thing that you're trying to avoid by doing the study that the conventional medical community says you should be doing to protect yourself. Now that sounds like a complete, there's all sorts of double hidden meanings with that kind of analogy, is there not? So these 3 reasons are reasons that you should be checking out, ladies, whether or not the emotion of the October season and all the pink in the atmosphere may really need to be seriously questioned in terms of your participation any longer. And I know your doctor, especially your OBGYN, is saying to you, hey, it's that time. You need to get your mammogram again. And each and every time that they see you, they say, hey, you're behind. You got to get the mammogram. And I will tell you, this is going to lead to a very unpleasant conversation one day with your doctors who think for some reason that this is a wonderful study that it is not, and keep on insisting that you do it. And so much as you'd like to try to avoid it anyway, your doctor's not going to allow you to avoid at least the conversation. Now, today's not the day to expand on it, but I would never leave you ladies questioning one of these procedures unless there was some other way. to assure you that this job could get done a heck of a lot better, protecting you, that is, against the possibility of breast cancer being present and not informing you early enough. And I think that's the word we should underline, early enough, so that you can actually do something about it and never have the metastatic spread, catching this thing at the millimeter stage as opposed to the centimeter stage. And I think if you've been a listener to this show, you probably already know that the next words out of my mouth will be that you need to consider thermograms and thermography, because they truly can detect cancers at that early stage. And that a 1 millimeter lesion, 1 millimeter, literally the size of the head of a pen, a ballpoint pen, lights up the size of my fist on a thermogram. You can't miss it. It is highly visible, even at that small size, due to a phenomenon that is referred to as neovascularization. It's a big word, I know, but it's telltale, and it sort of allows us not just to know if there's a something there, which is all the best that could be done with a mammogram. It can't tell you anything more than there's a something there. Unfortunately, it can tell you it much later than you actually need to know whether there's a something there. But in the case of a thermogram, because it's a physiological study, it's a biological study, we learn something much more than this. There's a something. We get to see its biological activity, and by looking at it, there's a certain signature, a certain look that a neovascular pattern provides that can't really be mistaken, and consequently, by virtue of it, not only can you know that there's a something, you can get a pretty good idea at a size of 1 millimeter whether that something is a malignancy or not. So I will get the girls. When I say get the girls, you know, we got two groups in Western Pennsylvania that do these studies, one called Three Rivers Thermography, and they're in my office once a month. There's another group out there across the street from South Hills Village in Bethel Park called HEAT. These are the two places to get this done. I hope you look at October as, oh, thank you, NFL, for the pink. It's time for my thermogram, mammogram, time for my thermogram, which you should be getting every year. And we'll close the topic for today, at least. So I can't let October go by without talking about it multiple times, but today was just the first installment. We'll close the topic of this issue between about thermograms by saying this. If you should ever happen to get the results of your mammogram back by your doctor, and the doctor says, got great news, we got the results from your mammogram, and you're clear as a breeze. There's nothing actually present at all, so we won't have to worry about anything this year. I don't know what you do with that information, because there's so many false negatives. Remember, it's difficult to see that I'm not so sure how good you can feel knowing that there's so much error with the study. And that just by them saying to you they don't see it, your question should be, and maybe it wouldn't be, but now I'm telling you that you should be pondering this, would mean that's a possibility that I have a lesion there and it was not visualizable, especially in the younger females where dense breast tissue happen to be more prominent than it is so in the elderly. But on the other hand, if we should get back your thermogram results, and it's clearly pointed out that this particular year there is no sign of any neovascular pattern, and consequently there is no sign of any malignancy, you can take that one to the bank. And you can really take the husband and go out and celebrate this year's results, because thermograms really don't miss. If you get a negative thermogram, you can trust it. And if you get a negative mammogram, I don't think you can. Anyway, that's my first installment and the month that gets me all riled up, called National Breast Cancer Awareness Month. I love the concept of the awareness. I do not like the concept of the mammogram. And so by the time November rolls around, each and every time I bring it up, you can say, there he goes again. And I'll be doing it quite a few times this month. I hope that I'm able to help steer you and how to think these things out to be able to make a correct decision. By the way, when you decide, if you decide on that mammogram, I'm with you. That is your call. And if you decide not to do that mammogram, that I'm with you 100% on that one too. But you got to be making these decisions with information, not with the lack of information. And unfortunately, what the 3 points that I just happened to tell you about, I don't see anybody talking about it. I guess I'll close with this. I keep getting emboldened every year by having this discussion with you, because in the ensuing year, after last October, I think I've counted 8 or 10 studies. And I don't know what they do over in Scandinavia, but the majority of these studies come from the Scandinavian countries, and one study after another study after another study throughout the entire year now has done nothing more than continue to bolster the notion that mammogram isn't worth the time or the energy to do it. In fact, because of the problems that develop from mammography and X-ray exposure, it's more than likely more hazardous than it is helpful. And these studies, I haven't come across one in the last year. Every time I'm reading one of these studies, it's another one of usually the Scandinavian country once again, who had some idle time on their hand. They're doing an awful lot of studies on breast cancer, and it just keeps pointing out how the mammogram is a loser. It's a loser. It's a loser, and yet it keeps on maintaining its prominence in the conventional medical community. At some point, something's got to give. And the give point will be whenever women decide, I'm not getting pushed in to having that study done this year. I don't care what my doctor says. When you get to that point and you're in charge of what gets done with you, to you, and for you, that's the way that the mammogram issue is going to go away. So, hope you can put up with it for me today, and I'll be talking more about it as the month goes on. And I get one of the girls to come on to talk about thermography this month because it is so timely, and we'll let it go at that. Okay, let's take a short break. I'm climbing down off of the high horse, folks. I'm back on the ground. Take a short break and come back. I want to talk to you about what I see coming up on the horizon for Western Pennsylvania. It's a paradigm shift, folks. If there ever was one, there's a paradigm shift in the making, and it's called microcurrent. Be right back.
Have impact on your health. One more.
Dr. Courtney?
Oh, yeah.
Are you taking calls?
Sure.
Okay, because we have somebody on hold.
Okay.
All right.
You need to do. Go to Dr. Courtney.
Good morning, ladies and gentlemen. Welcome back once again to AIM Impact on Your Health. Heard here on KHB 620 each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney with you today, and back after just a fantastic conference on Microcurrent. I'll be talking about that in just a moment. But also, too, wouldn't let you know we can open it up to you today. If you've got a mind to coming on in here, the number to do that, as you should know by now, is to dial us up at 412-825-6262. That's 412-825-6262. I listen for a knock on the door, and I will let you in the store. It turns out someone came a knocking. Come on in the store. Hello, welcome aboard. What's on your mind?
Good morning, doctor. How are you?
I'm well. How about you? How about yourself?
I'm good. Doctor, I don't know if you can help me with this little problem. I have a relation, my daughter-in-law, and she had a tumor around her, in her head on the side of her ear. And 4 years ago, they removed it. Well, now it's grown back again. And
absolutely, sure.
The problem she's trying to debate is that can anything be done outside of taking the radiation and the surgery? She's not quite sure what to do.
Well, let's just say when it comes to, there's two issues here. One is the fact that the brain is involved here. You're now talking about the most unforgiving organ or area that any malignancy could ever develop in. And the reason is this. The brain literally floats in cerebrospinal fluid. It's bobbing up and down there, okay? And so if you have a growth of abnormal tissue, malignancy, or benign, doesn't even matter. The problem with the brain is that it's floating there, and as it grows large enough, it's going to shift the entire brain away from it. It's going to push it away. And there's only one point that ultimately the brain is going to try to relieve the fact that it's being impressed upon, and that is it will be forced down through the atlas. The medulla is a sort of tapered off triangular structure that finally ends and culminates in a spinal cord, which will move through the atlas down to all the other vertebrae. The point is that this is a very ominous issue. The issue of removing the size of a lesion with the brain becomes imperative. And so this is one of those cases where to make certain that the person is removed from a life-threatening situation, radiation and or surgery really needs to be considered. You can't just say, "Oh, I'm not gonna do that," because the brain lesions are so unforgiving that it could be a tragic decision that somebody's making. So I know you may be surprised to hear that here I am actually in favor of whatever means there are to decrease the size of that lesion, simply because the brain won't forgive too much of an increase in mass without terrible consequences. Now, while that's being done, all the alternative measures, and I will absolutely tell you that the chemotherapy component of this is probably a questionable one, but shrinking that lesion, getting it under control so as to alleviate the fact that the brain will shift and it'll be pushed down to the medulla, and that has lethal consequences, has to be the number one thing on the mind of the individual who's afflicted with this. They got to get that. They got to be put in a safe zone before they can make the other decisions to whether or not to do conventional or unconventional therapy. But no decision really needs much time when it comes to, should I do this to get control of a situation that could get out of hand? And my answer to that question is absolutely yes. Am I clear about my answer?
Yes. Is it possible for you to say it was radiation or the surgery better?
Yeah. Actually, I'm going to leave that to the hands of the folks that at this particular point know best on what to refer, and I'm gonna back off of that one.
Okay.
Because they really do need to make. Sometimes it's a combination of both. but you got to get out of the threat of the lethal consequences to a lesion in the brain. Got to be gotten under control. Once under control, we can move into the non-conventional realm and be as beneficial, if not even more beneficial, from the non-toxic therapies that we have. But we got to get to that safe place first. And that's my story, and I'm sticking to it.
Thank you so much, Doctor.
You're welcome.
Bye.
Absolutely. Yeah. Pretty easy question to answer, folks. The brain just does not have the capability of responding in a slow manner when it takes a slide down the hill. It's terrible. It's terminal. All right. So as you can see, you can give us a call here at 412-825-6262. Be happy to try to answer any question. You can make any comment you like. I want to report to you on the microcurrent experience I just came back from. You know, we've been using microcurrent in my office now for it all started last July when Dr. Ed Conrad gave up the idea of doing these eye treatment programs himself. And microcurrent is the major, I believe it is the major modality in a 3-day program that really provides us with those fantastic results where we can say that 85 to 95% of the people who do the 3-day Conrad program will leave on day 3 with a substantial, I'm going to underline the word substantial, improvement in their vision in 3 days. It's almost unbelievable. You think, oh my God, that's not true. Well, yes, it is, and it has happened over and over again each and every month as we do these programs here in my office. Now, of the many modalities that we utilize in that 3 days, I think, and I'm pretty sure, that the one modality that probably has the greatest impact over that 3-day period and is allowing me to make a statement, as I just made a moment ago, that there's 85 to 95% with significant improvement, is this modality called microcurrent. We use it considerably during the 3 days, and I believe that when we reevaluate patients on day 3, and they're leaving me with the improvements that they have, that of all the things that we have done, the one modality that probably has allowed us to create such positive responses in such a short period of time is the microcurrent. Now, the microcurrent, which Dr. Ed Conrad has to be saluted for being able to come up with the use of microcurrent for eye problems, and it's, I think, the beauty of the Ed Conrad program, because as an ophthalmologist, he saw the utility of microcurrent, and he seized that opportunity, and he put these programs together with that use of that modality in order to be able to get those kind of results in such a short period of time. Before I answer this call, the point I want to make is, while Ed has been doing all that, other people throughout the United States have been using microcurrent in all other areas of the body other than the eye, because Ed has really been the one that has used the eye and the benefits of microcurrent on Ed. But I can tell you, these same turnarounds, these same wonderful possibilities that we found with the eye over and over and over again are being obtained with every other part of the body and with every other disease you can name. And I'll talk about that in just a moment. Microcurrent, I believe, is the paradigm shift that we've been looking for, and I'll report back to you in a minute. But let me answer this call and say, come on the store. Hello and welcome aboard. What's on your mind? Go right ahead.
Yes, Dr. Courtney.
Yes.
I have a question about my cousin. She's 48 years old, and she had a stroke last week. It was a minor one. She got over it okay. But they diagnosed her with a patent-forming oval with atrial septal defect, and the shunt is from right to left.
Yes. A patent foramen ovale. Yes.
Yeah. My question is, she's not too happy about this Coumadin thing they have on, and I would like to know if vitamin E and nattokinase could substitute that.
Well, in terms of the pathology itself, by the way, we're all born with a patent foramen ovale. As we are exiting the womb, there is a connection between the right atrium and the left atrium. that allow blood to pass from one side to another, because in utero, it doesn't really matter. But with the first breath of air that we take, there should be a sealing off and a complete closure of that foramen ovale so that after birth, it is no longer patent. In some individuals, and it looks as though it's your niece or whatever relative it is, the foramen ovale has continued. Now, all these years, she's 48 years old, you said, correct?
Yeah, that's correct.
Okay, and that there is a movement of deoxygenated blood from the right side of the heart to the left side of the heart, meaning that she doesn't get the full amount of oxygen when blood goes to the lungs and can maintain that, because the left-sided blood, which is fully oxygenated, is being able to mix with right-sided blood, and normally that doesn't happen, but it's deoxygenated blood that it mixes with, and so she's limited in the amount of activity she can partake in for her entire life, right? I mean, she's had this issue with getting tired before everybody else, getting short of breath before everybody else. Has that pretty much been her history?
Not necessarily.
She's been very active with her, so it's a very small defect. And
Yeah.
the reason that she's on the Coumadin and anticoagulants is there's a turbulence that develops when blood moves through that foramen, that opening, that hole.
Yeah.
And with turbulence comes the possibility of clot development. And it is for that reason that she's been on anticoagulants, pretty much her entire life?
Well, no, they just put her on Coumadin right after she had the stroke last week.
So they believe that she generated the clot that led to her stroke, and now that makes completely good sense.
Yeah.
As to whether or not she's going to have to remain on Coumadin, has she been told that she will have to stay on Coumadin forever? Is that what the doctors are telling her?
I'm not sure if they did or not.
I think I can tell you this. I have plenty of folks who have been placed on Coumadin for all sorts of reasons, and a preceding stroke was certainly one of them. And they're put on these rat poisoning kind of a thing so that they don't clot. And there's actually a pretty good way of doing that without the need for the Coumadin, and we should be able to discuss how we can use sliming platelets, which is easily done, as well as clot busting with the kinases we have. We have nattokinase and belucolumbrokinase. We'll be able to get to the same place that such a harsh chemical like Coumadin is able to provide with a lot of side effects. So I believe that anytime somebody is acutely afflicted, when did she have her stroke? How long ago?
It was about a week and a half ago.
Okay, at this particular point, she needs all the acute management that's afforded her. So at this point, nobody should be trying to do anything to get her off of Coumadin. She needs to be on it for now. But the good news is, once she's able to maybe get all of her faculties back that she lost, what did she lose?
She didn't lose anything.
Oh, good for her. So happy to hear that, because with stroke, you can absolutely expect that, at least for some time, there are going to be things to speak. Could be speech, could be walking, could be strength, could be you name it. I'm glad to hear that she really doesn't have any losses. But after this acute management, then we can talk about chronic long-term management and how to get off of those so that she doesn't have to be on it for the rest of her life. Okay?
Okay, and where do we proceed from here?
Whenever. Now you need at least I'm going to say 3 months of nothing, but following nothing but what the doctors are telling her. So she's in the acute phase right now. Let them do what they do best. But after about the 3-month mark, when everything is probably shaken out, that's the time to look at ongoing, long-term, long-range ways of intervening in this, and that's when come time to see me. All right?
Okay, sounds good.
Okay?
Okay, thank you.
Sure. Very good question. All right. Coming up here, we got getting close to the gong. Let's try to fill in some more salient points about microcurrent. Okay, we got Ed Condra. He's been out there for 12 years, putting eye programs together, getting fantastic results, one of a kind, kind of a thing, by using microcurrent. I believe it is the modality that has done the great things that I've seen for at least 6 of the last years, and for the last full year since July of 2013, in my office monthly, I've been able to observe and count on the use of microcurrent to be able to produce those effects. So I get thrown in after a 2 days course of how to program a microcurrent machine, which Sister Sarah and I blazed through and have now accomplished. The actual conference, the 8th annual Microcurrent Conference, began where clinicians came from all over the United States. I think the furthest traveled one was from Australia, and the next furthest was from Chile. They're coming from all over the world, folks. And this is the only group that in the country, or for that matter, I think the world, that meets with the discussion of microcurrent in mind. Now, we have seen something happen here that I refer to as the family phenomenon. Works something like this. A patient who's in an eye program and literally gets a microcurrent machine issued to them, and the microcurrent machine has 5 programs on it. One of them is eye specific. All the other 4 programs are body general. Things like inflammation, detoxification, stress, and brain balancing. These are general programs that help all the tissues of the body and are not eye specific. And Ed Conrad himself says that the eye benefits that somebody obtains, they obtain those benefits. 80% of the benefit is coming from the general programs and not the eye specific program that really only provides 20% of the improvement. I thought that was an interesting statistic that Ed finally revealed. The bottom line is this: these people go home, they're using these general programs, and other things that they're afflicted with start to improve. So one of the programs involves you hold the leads in your hand. Now, if you have an inflammation program you're running, and let's say you have arthritis of your hand and your wrist, I'm going to tell you something. In a very short period of time, you don't have arthritis to worry about anymore. And then you start talking to other members in your family about how this machine that you're using for your eye all of a sudden took care of this problem and that problem and this pain and this. And so the family member goes, hey, let me try that machine. And the family phenomenon begins. Other people who are afflicted with other maladies start in a, sort of like a one-timer, get a chance to use the machine, and in one treatment, they go home saying, my knee doesn't bother me, my wrist doesn't bother me, my shoulder doesn't bother me. And then we begin to hear questions about, hey, my eyes are all right, but I want to get one of those machines. The family phenomenon is underway. We're used to seeing it. We're happy to see it, but the benefit is happening in other areas other than just the eye. And I had a chance to meet some of the greatest practitioners throughout this country who've been working on this for quite some time. I actually have a unique relationship with one of them. Her name is Shannon Gosen. I'll let her describe that relationship because she did it to the entire group, and was rather intrigued by how she explained where we started and how long ago that was and what's happened and what's ensued. So I've sort of maintained now or developed a relationship with these folks. And Pittsburgh and Western Pennsylvania, I feel this paradigm shift coming up. We need to be using microcurrent in all these other areas that these folks who haven't been concentrating on the eye, who instead have been concentrating on all the other body issues going on, have been doing a fantastic job, and we need to do the same. One final thing I'll close with. While you were listening to the Jerry Tennant repeat show on Wednesday and Friday, I was also listening to Jerry Tennant. It wasn't a repeat show. It was Jerry Tennant. It was Jerry Tennant in the flesh, and Jerry Tennant, who is a member and was and has participated in the microcurrent conferences, was there. It was a very humbling moment for me. I admire this gentleman so much, and the fact that he lectured to the entire group, to me, was the highlight of that weekend experience. But there were case presentations. And so there were 13 people out of the 90 who went to this course that actually presented cases. And so I was one of the case presenters. I presented a case about a patient that I treated for eye diseases, glaucoma, who in 3 days jumped from seeing the first line of an eye chart. She jumped 12 lines to see 2015 on the end of 3 days. It's still a record in the Ed Condrat world, and I presented that case. And they were offering an award for those who presented the greatest case. And the award was going to be a handsome check and the prestige of knowing that with all the cases that were presented, that the group, the entire audience, got to vote on who they wanted to walk away with the first prize, second prize, and third. Well, I'm here to report to you, as I'm now bringing this, that I took second place with my case about the eye patient who jumped the 16 lines in an eye chart with an eye that was legally totally blind on day one and walked out of here seeing like an Israeli fighter pilot. I've never seen such a thing before, probably, and will ever again. But that's what happened with this particular patient. But I didn't win the big prize. No. The big prize went to somebody else. Turned out, the big prize went to the big man himself. Jerry Tennant won that prize. And it was very appropriate for Jerry Tennant to win it because he is Jerry Tennant, and he was bigger than life down there, humbling himself to present those cases. Oddly enough, as he started to present his case, he started describing a man who had pain in a foot, who had an enlarged spleen, whose blood count was severely low. His platelet count was below 50,000, and he was suffering from encephalitis at the same time. And when he determined that tooth 14 in this particular patient was responsible for it all and got that tooth pulled because it was root canaled, he was better in 72 hours. Of course, while he was telling the story, I knew, as you know, that he was talking about himself. He won his case presenting his own. That's what I'll leave with you. I'll see you on Wednesday. We'll talk more about microcurrent. Until then, this is Dr. Dennis Courtney saying so long for AM Impact on your health.